Welcome, everybody. My name is Vanessa Rojas, and I am a family nurse practitioner. I have experience in family medicine and occupational health. I've been practicing for about 5 years, and this topic is very special to my heart because I'm a patient myself. I have arthritis and have been living with it for about 15 years. And I'm also an immigrant from El Salvador. So in general, this topic is really important to me. And I'm happy to be leading this important discussion with, thankfully, really wonderful experts, which we'll get to know. The Hispanic Americans, as you may know, have a greater burden when it comes to living with arthritis. And so this particular topic is really important. There is risk for delayed diagnosis and treatment and experiencing more pain and disability. That's why tonight's experts and I will discuss key information to help you manage your symptoms and disease, including treatments, lifestyle measures, and tips to advocate for yourself so you can live a full life with arthritis. Let's move on to some housekeeping. Just so you all know, we have muted all attendees for this event, but you can direct any questions that you may have throughout the presentation in the Q&A box on the bottom of your screen. We will reserve time to answer all the questions at the end of our discussion. If you haven't already, please consider filling out the Arthritis Insights Assessment. It only takes about 10 minutes to complete, and in doing so, it really helps the foundation develop programs that speak to what is important to you. So it's really important to do that. After tonight's session, you will also receive an email asking you about your experience tonight. These surveys really help track the success of the sessions that we carry and better plan for future events. So please take the time to fill them out. It really helps. I'd like to get started by introducing our wonderful expert panel. I spoke a little bit about myself already, and now I'd like to introduce the two experts that will be leading most of the discussion tonight. We have Dr. Geraldino-Pardilla. She's an associate professor and director of the Lupus Clinic at Columbia University. She graduated from the Intec University in the Dominican Republic, and afterwards moved to New York to complete her training, including a rheumatology fellowship at Columbia University, where she stayed as a faculty member. Her areas of clinical and research interest include lupus, rheumatoid arthritis, and musculoskeletal ultrasonography. So welcome her. Please also welcome Dr. Erick Santos. He is a general orthopedic surgeon who practices in South Texas with an office in McAllen, Texas. Dr. Santos was born and grew up in San Juan, Puerto Rico. He attended the undergraduate studies at Johns Hopkins University with a Bachelor of Science in Biomedical Engineering. Then he attended the University of Pennsylvania, where he got a master's and PhD in biomedical engineering and also got his MD. He served in the United Air Force as a flight surgeon, and then completed his residency in orthopedic surgery at the University of Alabama in Birmingham. Wonderful. He has also been an orthopedic surgery professional practicing in South Texas for 17 years. He's strong interest in diversity and equity and inclusion. He serves on the steering committee for the Movement of Life and mentors students throughout his involvement in the Nth Dimensions at AALOS. Thank you all so much for joining us tonight. We are really excited to share this time with you and hope that you come out with wonderful knowledge after the discussions. To kick off the discussion, we'll discuss how attitudes and biases in care settings affect Hispanic Americans and how to find a doctor that is right for you. I'll start by asking a question first. We've learned that the Hispanic community experiences more pain, greater chances of disability, and delays in treatment and care. But what are some of the key factors that are driving those differences in care? Dr. Geraldino, would you like to get us started?
Thanks, Vanessa. And that's a great kickoff question because, as we can envision, there's multiple factors that play a role into why that is the case, not just with increased pain, but more likelihood of disability and delayed care in general. So some of the issues stem from not only cultural practices and beliefs. It might be perceived as a weakness, for example, to be seeking medical attention, or it's things can be attributed sometimes wrongly to, oh, this is probably an aging process, or it'll go away. It's not really anything very important. But also mistrust in the healthcare system. There's been precedent for minorities not having good experiences with health issues in the past, misinformation, especially during the pandemic we had. So I think all of those have grown to play a role, but also important things to mention are socioeconomics. So it might be that our Hispanic populations in some areas are probably not with high socioeconomic status in some cases, and that leads to then less access of care. They might be uninsured, or be dealing with immigration status that can perhaps not encourage them to seek medical attention, not knowing whether that would have some implication to their immigration status or not. But also, the fact that all of these things occur and line up ultimately lead to then that delay in getting to that physician. So by the time that encounter takes place, it might be very advanced, or the disease might be severe, or irreversible damage has occurred. And the way we think of arthritis, I'll just back up a little bit. We think of them as two main groups. Those arthritis that we know as osteoarthritis or degenerative arthritis, we call wear and tear arthritis, all the same thing. And then we have another group, big group of arthritis, which are the inflammatory arthritis, things like rheumatoid arthritis. So, in particular, for that second group of diseases, we really want to make sure that a diagnosis is made promptly, that treatment is started as soon as possible, because we know that the longer that inflammation goes on uncontrolled, not treated, then erosion start to happen in those joints, destruction, and with that, those are things that, again, we cannot reverse with any of the treatments that are available at the time. So that would lead to disability, more severe disease, more difficult to treat scenarios. So in a way, it's a combination of all of those factors that then can lead to worse outcomes in our Hispanic patients.
Very well said. Dr. Santos, would you like to add anything to what she's already said?
Oh, those are all excellent points. I think that socioeconomics and immigration status and language barriers all go into access to care for the Hispanic population. And usually I'll see the patients in a more advanced stage of their arthritis, probably when they're closer to having surgery. And by that point, a lot of the options are less for those patients. And so, really, if we can get them at the primary care stage and early on to keep those patients moving and try to keep their joint health better, then hopefully they can avoid surgery.
Very well. How can some of the cultural attitudes about seeking care for arthritis contribute to poorer health outcomes? What advice would you give the patients to combat these attitudes for better care? Dr. Santos, would you like to start with that?
Sure. I think a lot of it is information and education of the patients. Giving them good information, uh, being able to relate to them so they are able to absorb the information and trust you as a physician, and also involving the family. In many Hispanic communities, family is really important. A lot of times, the male, the family doesn't want to come see the doctor because they're basically dragged in by their wife or girlfriend or daughter or somebody like that. And so, once you get them in, you got to really focus on that education and building that trust so they can get treated.
Yeah, yeah, those things are all true. As we all know, Hispanic Americans aren't sometimes taken seriously. So when it comes to reporting their pain, sometimes patients may feel like they're being dismissed. So the question is, what should someone do if they feel like their doctor is dismissing their needs? I'd like to answer this question myself because, as I mentioned, I'm a professional, but also a patient myself, and I've been on both ends. And truthfully, that that would be a really difficult situation. Gratefully, I haven't lived it. But if someone were feeling like their concerns are being dismissed, I would 100% encourage that person to open up an honest opportunity for that provider to understand that the patient is feeling this way. So if I feel that my provider is not listening to me, I would confront that attitude directly with my provider and say, I feel that I'm not being heard. The reason I would do this is because I really believe that if you've developed any kind of a relationship with your provider, you should give them a chance to correct themselves when they're wrong. And it is absolutely wrong for someone not to provide knowledge that they are listening to what your concern is. And so once you do that, if you really feel that the provider doesn't respond adequately in exploring your concern and taking action in what is important for your health, then I would say it's time to look for a different provider, because trust is one of the most important things that we as patients need to have with our providers. And if you don't have the ability to be heard, then that trust is being broken. And that is one of the most important things that you can develop with a provider. So I encourage you that if you feel that you're not being listened appropriately, that you take the time to express that and act upon that. Anyone else is welcome to share their idea.
Jump in. Yeah, Vanessa, was what you're saying. It's the basis of a good patient-doctor relationship is based on that communication, that effectiveness of communication. And but while you say yes, ideally, if you feel that your health issues are not being addressed, you should express it. Make sure that the message is getting across to your provider, but not everybody feels as comfortable doing that. And I think that's where some of the problem comes, because if your doctor knows or realizes that you're not doing well, you're not really improving, you're feeling terrible, they're really going to try to do their best to help you. But something that I've observed, especially in some patients that of mine that have seen other providers before me, and one of the things sometimes they tell me is like, "Oh, I feel so great that I can just freely talk to you." And but sometimes, that implies they did not feel like that with other providers. So and it might be that the provider doesn't even know really what's going on. They think that person's doing relatively okay, and it's not completely dismissing the symptoms, but there's that paternalistic view of the provider by some of our Hispanic population. So they think, okay, he must know or she must know what they're doing, and okay, I mentioned the pain, but didn't really emphasize it to the extent maybe that you should. Okay, they prescribed that, it didn't help. Maybe I'll just stop taking it, and then I didn't mention it next time because they already gave me something and it didn't really do the trick. So yeah, so that basis of effective communication is essential. And if it's not achievable with your current provider, you absolutely must try to change that provider, because it's going to be a long-term relationship. Yeah.
Yeah, I
All right.
100%.
Sorry,
And
I have a
yeah, go
quick
ahead,
point.
doctor. Go ahead.
Yeah, a quick point on that is usually in my encounters with patients, I always ask them if they have any questions at the end to make sure they can express that. And I would encourage that of any patient that if your provider or physician is not answering your questions, that's a red flag. I mean, and one of the other things I tell them, look, if there's stuff you think about when you're home and you're not at the visit, write it down, all your questions, and the next time you're in the office, I'll be happy to answer all the questions point by point.
Yeah, that's really wonderful that you do that. And on this topic of communicating with your doctor, there's a question here that I think is really important. How can patients communicate more effectively with their doctor to get the care that they need and overcome these biases? Dr. Geraldino, let's start with you.
Yeah, I think just knowing that you have to freely express everything that's a concern. Don't worry if you think, oh, the doctor doesn't have much time or this or that or the. No, you just have to make sure that you express all your concerns. Not there's not such thing as a dumb question. It might be something really important, and it's good if you bring it up to the attention of your physicians. And so Dr. Santos mentioned how bringing somebody to the appointment. I love that too. Bringing a family member, a friend is so helpful, because the information can be overwhelming, especially at the initial diagnosis, for example, of something like an inflammatory arthritis. It's just a lot of information. It could be overwhelming. And to have more than one person there listening to all these instructions, all this education, all of these things, and maybe reminding you of important things you forgot to mention at the visit, it becomes very helpful. So I think having that improves also that communication.
Good. One thing I always do before I go in to see my doctor is that I write down all the questions that I have. Because oftentimes you get caught up with like new information, like you said. There's a lot going on, and you may forget what's important to you. And as we all know, rheumatologists are really busy, so it may not be as efficient to communicate after the fact. It's better to get all your questions answered, so make sure you write those things down that you need to communicate, especially when it comes to concerns and things that you want to discuss face to face.
Absolutely. One of the good things with actually telehealth is that, there's more access now in that way, that you can quickly, my patients shoot me a message, pops up like a text message for me, and anything they just thought at the moment. And so
That's true.
that improves some of that access too.
Yeah, so if you forgot something, don't forget to send a message. Now, when is it the time to seek a new doctor? Anyone?
I mean, if somebody's being disrespectful, if they're not listening to your concerns, if you're losing confidence in what they're doing, then that would be the time to seek a new doctor.
And what qualities should patients look for when it comes to finding a new doctor that knows how to treat the Hispanic community? Dr. Geraldino?
Something that I've heard from a lot of my patients that they find helpful is to actually either have a physician that speaks their language. Sometimes things just get lost with interpreters, and people get frustrated on both ends sometimes. And so perhaps finding a physician that does speak your own language, and making sure that you just feel that you're well cared for. It's a very personal and long-term relationship that has to be built, and trust and open communication has to be a part of it. So I think those are some essentials there. One other thing with the like, when is it time to consider switching, is also, I've had patients that tell me, that I've been telling my primary care for a long time to send me here, to send me to a rheumatologist. But they said, they're not going to do anything different. I'm giving you the pain medication, or I'm sending you to physical therapy. And perhaps they had a completely different arthritis, that it was good that they did come. So that's another issue that we face, that when we look, for example, at the Hispanics with inflammatory arthritis, particularly rheumatoid arthritis, looks like there's sometimes 3 times the delay in that person being referred to a specialist.
Yeah.
So
And I'd like to share a little bit of my experience with that. When I was diagnosed, it took a long time for me to find the right rheumatologist. But once I did, I could tell my health was doing better. My concerns were being addressed, and I had good communication with my doctor. I could access him easily, and he had the most up-to-date information that I felt was helping me. And once I found that, I didn't let him go. So right now, I don't know if you can tell my background. I had to travel about 6 hours to come see my rheumatologist. I'm not encouraging this, but what I'm saying is when you find the right person, you have to value that and do what you got to do. So my doctor and I have been in a relationship for 15 years, and he's kept me healthy, and he's an important part of why I'm doing what I'm doing and able to succeed. And so I encourage you to not be complacent when it comes to finding the right partner in leading your health. It has to be someone who's knowledgeable. It has to be someone who gives you the support that you need and who's there for you when you need it. So all of those things are really important in the success of treating your rheumatoid arthritis. Now, Dr. Santos, can you please add your perspective regarding access to orthopedists and orthopedic surgeons?
Well, and a lot of this depends on where you live. For example, in my area, the Rio Grande Valley, where I practice, there are a lot fewer orthopedic surgeons than in a big city like New York City. And so usually there's pretty good access to orthopedic surgeons. The question is whether or not you get somebody who's going to spend the time that you need, especially if it's a complex problem. A lot of the orthopedic surgeons that I know, it's a very quick visit. If you need surgery, then they'll immediately get you into surgery. But if you don't need surgery, they're going to kind of shunt you over to one of their PAs or somebody like that. And for me, I think it's important to find somebody who can spend the time with you to attend to whatever's going on in your condition.
Yeah, really important. And likewise, many patients who need a rheumatologist may not have easy access to one. So how can primary care doctors and rheumatologists work together to comprehensively manage a patient's arthritis in care? And I'd like to weigh in on this as a primary care provider. I think we do have the ability to uh, play a role in keeping someone healthy when a rheumatologist is not easily available. Um, I have had patients who, can't get an appointment soon enough with their rheumatologist, and I've been able to contribute in communicating with a rheumatologist and facilitating an order or facilitating a medication, a prescription, and maintaining that patient well. But I think it's also been helpful that primary care providers have a good knowledge of the overall well-being. So we can see when something is out of norm and be able to communicate to the rheumatologist when there's a concern. So I think there's value in keeping a relationship with a primary care, especially if you have a rheumatologist that's really busy, not as accessible, not easily, you can't get an appointment quick enough. So I think there's value in that as well.
absolutely. So, and not only in underserved areas, yes, there's some locations that really don't have rheumatologists in over 100 over miles, and it becomes really difficult to force the access. So even more so there in those situations, it has to be a true close partnership with the primary care providers so that, care is provided in a timely manner, treatment started promptly, and so forth. So even more important there. But in general, it's still important, even if that's not the case, because yes, we focus mainly on the arthritis manifestations, but we know that a lot of the inflammatory arthritis don't just involve the joints, and other things can be going on. So it's, and maybe the primary care will be the first person who would identify those symptoms, whether it's that the rheumatoid arthritis is affecting the lungs now, um, or it's affecting, there's some cardiac, some heart consequences from that. So it does become really important to have that partnership. It's a team, and there's numerous members of that team, and the primary care is an essential one, obviously.
Yeah, I agree with that 100%. I recently had a patient who, um, had an autoimmune condition and rarely saw her rheumatologist, and I was able to assist in referring to other parts of her body that were being affected effectively. And I think it's important to have someone on board that you can access maybe easier or more promptly than you can a rheumatologist. So 100% get in touch with a primary care who you also can trust and who has an understanding of your prior health. Yeah.
The medications is a big issue there sometimes, because patients think they have to wait for their appointment if they're running low on a medication, and they might see the primary care provider and they might be told, I cannot prescribe that. That's for your specialist, that's for your rheumatologist to prescribe. And then that patient might be without medication for God knows a month, 2 months, and then have a flare and things like that. So
Yeah. Things that I've done in the past when I've had a situation like that where I need another provider to step in is that I've just connected them to my rheumatologist, and that's been helpful. So maybe ask your rheumatologist what's an easy way for another provider to get in touch with them, where sometimes it's just faster and easier for them to communicate, and someone else can assist in getting everything on board versus having someone just say, I can't help you with that. When they have the support of a rheumatologist, any other provider seems to be more open to stepping in and sort of working in a team. Our next topic is going to be about working with your doctor to craft a treatment plan that is right for you. So, Dr. Geraldino, how do doctors decide which medications to try first?
So, in general, when thinking of inflammatory arthritis, in particular, rheumatoid arthritis, the approach is that we try to start with the medications that are known to be effective but least toxic, and less side effects. And as a general rule, we start with methotrexate for rheumatoid arthritis. And if things are not going well, if there's failure to that medication, then we escalate. So it's like a second step of bigger guns, to put it that way. So stronger medications that are better able to control the inflammation. And we have several different things. Those injectable pens, or it could be infusions. There's pills now also for those stronger kinds of medications. And the way to pick one versus the other is it's tailoring it to what are the needs, and what are the safety issues that we have to worry about with each medication, based on what are some already underlying medical problems that that person has. So it's very tailored to um, not only how severe is the arthritis, but also are there some other medical problems that might put you at risk for one versus the other in terms of thinking of medications. So that's just a broad thing, but thankfully we do have a lot of alternatives. So it's an exciting time in that sense.
Great. Are there certain medications that are better than others when it comes to treating inflammatory arthritis versus osteoarthritis?
So for osteoarthritis, the focus is quite different. It's mainly to control pain and keep functionality. So good pain control with good exercise regime and physical therapy and things of that nature are the drivers there for the treatment. And once things are advanced, of course, surgery becomes an important option as well. But for inflammatory arthritis, Yeah, so when I was saying bigger guns, that's second step. So all of those medications are known to be more effective that are starting line, which, as I said, methotrexate. But because methotrexate is a safer drug and half of the people will do very well on that, will respond to that and not need anything else, it's worth doing that. But if you say, are they better? But certainly the stronger ones are more effective in just controlling that inflammation, but they come with more side effects. So it's always that balance between efficacy, it works well, but also that it's safe and it's well tolerated. So if somebody is doing perfectly fine and gets into remission, all the arthritis is well controlled with a lower GON with something like methotrexate, then that's ideal. But if not, there's numerous alternatives. So that's the way to think about that. Don't feel that if you're started on methotrexate, you should have been started on something more efficacious. It's better because it's always that balance. If you can be control on something that is potentially the least toxic, then the better.
Very good. And how can our audience rest assured that they are being prescribed what is right and what is going to work for them?
So, and I said that now we have the luxury of multiple alternatives to treat rheumatoid arthritis. So, whenever you are not controlled, meaning that you're still having swollen joints, you're still waking up stiff in the morning, lasting 30 minutes, an hour or more. So those are signs that the arthritis is not controlled. So the goal now is that the arthritis should be fully controlled. We have numerous medications with to achieve that goal. So if things have not reached that point with the medications you're taking right now, then that's an opportunity your doctor should be noticing. But if somehow they're lingering with the same treatment, is this time to change to a different medication? Because there are numerous options, so there's no need to stay with one that's failing. The goal is that the arthritis should be fully control, meaning no more swollen joints and that stiffness to go away.
Very good. Are there certain medications side effects more common in Hispanic Americans? Is there anything that's more like noticeable with the Hispanic community?
Not necessarily with the side effects, but we know there are some within that group of medications that I said is the second step that are bigger guns, the biologics. There's a group of medications, the JAK inhibitors, that are particularly associated with, they have greater risk for having cardiovascular events as a side effect. So things like a heart attack, for example. It's a higher risk with that particular group of medications. So in Hispanics, what we tend to have is more in certain groups, because Hispanics, of course, groups a lot of different racial, ethnic backgrounds, but more higher rates of obesity and hypertension, high blood pressure. So if you know that there's a lot of risk factors for those cardiovascular events, so things like heart attacks, so then you might be more cautious and not want to jump on those as upfront as your first line, just because of being cautious. Or if there's been some history of having had a blood clot, that's another situation in which you'll, and your physician will orient you towards other groups of those medications. But it's very tailored to what's the background, what are the risks for each individual, to see what will be the safest and yet still effective treatment to start.
Very good. And are there any particular things that you would suggest for our patients to look out for when they should notify their doctor? So in that realm of things that you said, like that are high risk, what are some things that people should look out for and be alerted to let their doctor know once they start these meds?
Great question. So the main side effect potentially with all of these medications for the arthritis that are within that group of biologics or bigger guns to treat the arthritis is infections, because as they bring down your immune system, it's like the same immune system that would fight an infection is the same immune system that would be fighting against your joints. So to calm down that inflammation in the joints, then what suffers is then your ability to defend your body against things like infections. So we always try to make sure that vaccines are up to date so that we have less risk for infections. But anything that could suggest an infection, you're having a fever, you're having a cough, you're having burning with the urine, you're having diarrhea, anything that would be suggestive of an infection is something important to report, because it's likely linked to being on medications that are bringing down that immune system.
Very good.
Yeah.
Why do some patients still have pain even though their doctor says their arthritis is well controlled? Is this bias in care or could it be something else?
And I'll jump in that one. So, but yeah, it's sometimes hard to distinguish, especially from a patient point of view. I mean, if I'm not feeling well, how could somebody tell me that I am controlled? But it's a couple of things. So we, especially in our Hispanic patients, we mentioned how there's that delay in seeking medical care and more severity by the time they actually see a provider, and there might already be erosions and bone destruction in those joints. So no matter how good the medication that we start for the arthritis, those things that are already damaged and irreversible don't regress. So they will continue to cause pain. It might not be that inflammation is still happening. It shouldn't be that inflammation is still happening. Like the joints shouldn't remain swollen. You shouldn't still be having that stiffness, but pain, because there's already been damage, is usually the reason of why people find it hard to accept that. How is my rheumatologist saying this arthritis is control? I'm in a lot of pain, but it might be directly related to that damage that already occurred and we are not able to fix. Dr. Santos is able to fix that by giving you a new joint, but it's not something that the medications are able to do. It doesn't mean that it shouldn't be addressed though, and there's a lot of ways to deal with chronic pain and pain management centers, so that could be a great resource. But damage that's already occurred is not something that our medications are able to reverse.
Yeah, understood.
And to that point, you also have to be careful because sometimes people complain of knee pain and it may be due to other causes. For example, hip arthritis can manifest as knee pain. I've seen people with kind of mild arthritis in their knees, and you treat them with injections. They don't do anything. You get x-rays of their hip, and their hip arthritis is really bad. Or spine, you'll get a lot of manifestations from spine arthritis or spine conditions that can manifest as pain. So you also have to be careful and kind of look at other causes of pain that could be manifesting, and not just the arthritis.
Very good. Thank you for that, Dr. Santos. Now let's move on to prognosis, which is our next topic. Are there any genetic components that make Hispanics more susceptible to arthritis than other ethnicities?
One of the most common arthritis is actually that wear and tear or degenerative osteoarthritis, and the higher risk for that for Hispanics is really the link with obesity. So the greater the obesity, the more the more burden we're giving those joints, and in particular the knees that are helping us stay up and sustaining all of our weight. So that's where we see more of that link.
Ese es en donde vemos en ese, ¿no?
I'm sorry. Okay. So that's where we see more of that link with when we have higher risks of obesity in our Hispanic population, and then having more knee osteoarthritis due to that burden there. Yeah, not so much for the inflammatory arthritis though.
Okay. And then how fast does arthritis typically progress for Hispanics once diagnosed?
So when we're talking about inflammatory arthritis, like rheumatoid arthritis, for example, we know that, the progression really depends on if you're not controlling it. So how delays treatment and achieving that remission. And we know that because there's that delay in just that initial encounter with the provider, that we tend to see more severe arthritis at presentation. And then with that more damage, and then less likelihood to really achieve that remission. But in general, if the inflammation is not controlled, in 2 years of uncontrolled inflammation in those joints, that already half of the people will have some bone destruction. And in some of the studies when I was referring to before of that delay and how many months it would take to present with the arthritis, we've seen that in some studies, Hispanics take up to 23 months. So that's already close to those 2 years where already half of people might already have those erosions and bone destruction. So it could be very impactful to their daily life and disability.
Thank you for that. We're running a little short on time, so I'm going to skip a couple of the things that we've had planned to talk about, and I want to jump into joint surgery. Let's discuss joint surgery by inviting Dr. Santos to answer some specific questions. Is joint surgery inevitable with arthritis, Dr. Santos?
It doesn't have to be. I mean, you can manage mild arthritis, with medication. Aleve, ibuprofen work very well. Regular Tylenol. We do things like injections with steroids, Hyalgan, or other types of injections. Really, what I tell my patients is that surgery, especially joint replacement surgery, like replacing a knee or a hip, is something you ought to consider if it's interfering, the pain is interfering with what you want to do in your life. You can't walk and you can't do the things you ought to do. That's when surgery really ought to be considered. And it's a process. I mean, I'll see the patients, we'll advise them. First thing we do is take x-rays and then see how bad. And sometimes I get them pretty advanced where it's pretty much bone on bone, and they're basically every step they take is painful. At that point, then we really should start the process towards doing joint replacement surgery.
Very good. One patient wrote in, I'm in great deal of pain, but I am not comfortable with the idea of surgery. What are my options?
So again, the first thing is weight loss, medication, physical therapy. Once you kind of get through those things, then you can get injections. Steroid injections do seem to help buy people time. You can also inject other things in the knee, hyaluronic acid such as Hyalgan or Symvist. There's other injections such as PRP or stem cells. There's a few things you can do before you get to the point of surgery, but at some point, if it's bad enough, then surgery is probably the best option.
Yeah. So you've answered the next question, which was, when do you know it's time? Basically, you've tried everything else and failed, is what you've shared. Is there anything else you want to say to that? When should a patient really resort to that surgery option?
Yeah, I mean, I think that it's a personal decision.
Yeah.
One of the things that I do is I have a discussion with the patient and their family and say, look, this is what you ought to expect from surgery. These are the risks. These are the things that you ought to expect from surgery. Sometimes I'll put them in contact with a patient who's had a knee replacement surgery so they can talk to somebody who is probably similar in age to them. They might relate to and tell them about their experience. I mean, these days, there's a lot less pain involved with these major surgeries. We do stuff like nerve blocks. The hospital stays are much lower, and the management is much better optimized. But I mean, these are sometimes rough surgeries, and so you got to go in with your eyes open and try to be well informed about what you're getting into.
Yeah. Yeah. What should someone reasonably expect after getting joint surgery? Will their pain go away completely?
Yeah, so if things are successful, so usually what'll happen is we'll do surgery. The patient will stay in the hospital for a day or two. There, the first couple weeks, there's going to be pain from the incision while it heals, and usually by about 6 weeks, things are a lot better. People are walking, maybe even without a walker or any assistance. I usually tell people by 3 months you should have probably about 90% of your pain gone. It's not going to be 100%. There's always, with mechanical joint, there's always things that aren't going to be quite perfect, but you may get quite a bit of pain relief from the surgery. Usually by about 3 months is a good point where when things are successful, you'll know it for sure.
Very good. Thank you for that, Dr. Santos. I'd like to ask, well, actually, let's move on to our next topic, which will be the lifestyle, exercise, and diet topic. Is there a best diet for arthritis? Can certain diet help cure arthritis? Anyone is welcome to answer this question.
Jump in with cure, no. So we wish. But having said that, well, there's no diet that would cure arthritis. So we know that there are diets that lead to less inflammation, and that's our goal here. So actually, I got two goals here. So we want to maintain a healthy weight because, as we were mentioning, obesity worsening the arthritis, not just because of the burden of that weight, but also because actually the fat tissues, the fat portions in our body, those are actually making molecules that promote inflammation. So
Ah,
you can see fat as your enemy and causing inflammation. Not only its physical burden that it puts on the body, but also that inflammatory component. And when thinking about diets with, less inflammatory like promotion, so the Mediterranean diet is the most favored diet. So what we are looking for is a diet that's rich in vegetables, fruits, grains. So favoring fish and because they have a high content of omega-3s, so those are great. Our goal here again, trying to minimize inflammation. So also the fruits help us in the part of like having a lot of antioxidants, so that takes care of something called free radicals that are also molecules that promote that inflammation and in general have worse outcomes. So, yeah, you were going to ask something, Vanessa. Did I?
oh, no, I was just going to ask. The next question is: does insurance cover a nutritionist? So, if someone wanted to get more help in getting more detailed information about what you've shared, is that usually something that is covered by their insurance?
So it's not all insurances are made equal. So there's some of that, but it's not so hard to get the nutritionist, at least an initial visit. It's harder when it's like more for chronic and sustainable follow up to get that covered. But a lot of other resources like and the Arthritis Foundation website, like websites on specific diseases, become very helpful. Of course, all the educational programs, things like this, but the nutritionist can become a good resource. And also, when we're dealing with weight, as a detrimental component here for both inflammation and burden to those joints, specific designated weight control centers become really important.
Yeah, I agree. I did want to take a quick minute to speak to my Hispanic background. I know in my culture, there's a belief that specific foods can cure rheumatology issues or inflammatory issues. So I know there's like things that I've heard, something like honey can cure it, and people will become really determined to practicing these dietary food recommendations in order to heal their inflammation. And I just wanted to encourage you to ask your doctor about these before you practice them as sole modes of treatment for your symptoms. It's important that you share these beliefs with your doctor so that they can help give you the resources available so you can have more information and make a better decision for yourself. The next question I have here is, what are the best kinds of exercise for arthritis? This is an important one as well. Dr. Santos?
Yeah, so one of the things I recommend to my patients who've got arthritis is water aerobics. You know, anything you do in the water, you're not going to feel the pain in your joints because you're not putting that weight on your joints. I think anything low impact, you know, such as walking or riding a bike, is good to keep the joints moving. You know, and I think that's important because if you know, there's studies that say that if you're immobile or not actually moving every day, that your arthritis is actually going to get worse rather than better. And so, you know, even if it's a mild walk or something like that, then that'll help keep your joints healthier.
Very good.
Yeah, and
Okay.
I'll just jump in with something real quick there that not only for the exercise itself, but when the inflammation is very active, your muscle mass actually gets wasted. So so to build that endurance in your muscles becomes really important, and more so when you're taking things like prednisone, steroids, which have a bigger impact on that, substituting the muscle, the normal muscle, for fat. So it becomes really important there as well.
Very good. Many people may have lost their jobs or insurance during the pandemic. What are some of the options to care for if someone doesn't have insurance, Dr. Geraldino?
So something to keep in mind is that the city hospitals are always options for that won't require insurance, and often I know it's very dependent on the specific state, how what's the wealth of those benefits. But they often will cover not only like the visits, but whatever blood work, X-rays, imaging, or medications as well, that would be required. So with very few exceptions. So make sure that, you know, if in doubt, the first thing will be to be in contact with your provider if you lost your insurance, because they will be the best to tell you, yes, go to the city hospital, go to my colleague here, put you in contact with that person, facilitate that encounter happens in a timely manner. So all of those things, and often this has happened to some of my patients. They lose their insurance, and then they only tell me once they come back. I'm like, no, I could have helped you go get in here, get this medications. Another great resource is, you know, the different organizations for that type of arthritis, and the different pharmaceutical companies. They often have some patient programs that can help quite a bit, even not just with co-payments, but just in general with sometimes just completely free medication, and samples that your providers have been storing for times of need, is something to keep in mind. You run out of your medications, run out of your insurance, first person to tell is your doctor, because they might be able to get you through a month or so while things get figured out.
So you've already sort of answered this question, but any other resources for treatment and maintenance for arthritis care that are available for people on Patient Protection Affordable Care Act, anything like that, that you might want to add?
On that end, I think it's more related to the specific pharmaceutical companies that have very good patient programs, and usually they try to bridge or keep the medication going when things like this happen, of people losing their insurance.
Yeah.
Um,
Okay.
And I'd like to also make a plug for the federally qualified health clinics, because they have sliding scales as well. They take people without insurance as well, and try to work them in, because usually we have at least two in the community I'm in, and they're a good resource for people, especially if you lose your insurance.
Okay. And then can you briefly talk about the importance of emotional mental health and why it's so important to manage arthritis?
Well, it's all a whole, right? We need to be both physically and mentally healthy, and some of those things, we know that stress is a contributor to worsening arthritis, and we see often flares in those situations that are highly stressful. So yeah, so it becomes, I think, more so with the pandemic, where stress levels were through the roof amongst everybody. It's become more easily spoken. I think in our Hispanic community, sometimes there's a bit of a taboo of talking about any mental concerns, because, again, perceived as perhaps some weakness. And it's not something that people are often too open about expressing. And so, I think a way to just open those discussions, just at least personally knowing how stressful at least the pandemic times, where I just open it up for everybody. How are you doing? I know how things are. It's so tough. And then that just, everybody needs help. And just that makes it, that gives them an opportunity to open up on things. But especially in our Hispanic community, there's sometimes some reluctance to really open up about that, and or seek help. Like, if you mentioned, have you thought of getting some help? And I usually tell my patients, everything that helps and makes us achieve a better health status, we embrace that. Let's just embrace everything that helps. Who cares what? Don't worry. Our goal is to be as healthy as possible, and whatever gets us there and it's tolerated, let's go for it.
Yeah. Yeah, and we'll keep chatting just a second more about that, but I want to open up for questions and answers. So the chat will now be open for questions to come in. Keep in mind that we've received several questions before the webinar, so we'll try to get through as many as possible today. We are now in a little bit of a time crunch, but we'll get to as many questions as we can. And while I wait for these questions, I just wanted to say the mental health part of it, as a patient myself, I think is extremely important. I've been in difficult situations where my health wasn't as good as I wished for it to be, and addressing the mental stress was equally as important as addressing the physical health. So don't minimize that. I wanted to really share that as a patient myself. So here's an important question. How can someone eat a balanced diet for arthritis, as their nearest grocery store doesn't always carry the healthiest food?
Hmm. And that's a problem, that especially sometimes in Hispanic communities, we see that we don't have those ideal grocery stores with the most nutritious items. But so some resources for that is, I think it's an effort that most of the medical centers are trying to implement. Is like, for example, we have a day, Tuesdays, we have a farmers market that comes and settles around the hospital. And so that's a resource. So we tell our patients, like, okay, this is an easy place for you to get your fruits and vegetables. So trying to find out about resources like that, often with your physician, they might be the source of giving you those details. And also, especially if you're attending, if you're going to a place that has an arthritis center, there's usually resources there and counselors, and that can facilitate some of those locations. But the farmers markets has been a great success, at least in our community, and it's helped a lot with that.
Excellent. Are there newer medications that help with pain that are not opioids and therefore are not addictive?
So not just new medications, but last decade or more, we've turned away from the use of opioids for chronic pain because we've realized that's not really what they're good at. It's meant the opioids are really meant to be for some acute circumstances, post surgery, things of that nature. But when we're dealing with chronic pain, the medications are completely different. So the focus is mainly on antidepressants and medications like gabapentin, Lyrica become very beneficial for those for managing chronic pain. So yes, so and I mentioned before, but attending a pain management center can be quite helpful because they're quite on things and switching and playing around with things, making sure the goals are achieved for pain control.
Good. Next question. What options are there for a person who has osteoarthritis where the injections in the spine and other areas are not offering any relief? The pain is 10 and all over.
So, you want to be focused on where, what's causing the pain and how to be able to treat it. If it's all over, I mean, it could be something like fibromyalgia or some other conditions which cause chronic pain all over. If it's a spine condition that's causing pain, then they might want to see a spine surgeon or a pain management doctor that can look to see if there's some treatment options for the kind of pain. I mean, it may include surgery, but it may be other things that can be done short of surgery to try to relieve that pain.
Very good. Any new advances with osteoarthritis treatment and comorbidities such as musculoskeletal spinal myelopathy?
I think that's quite specific. I mean, and people who have spinal conditions and have osteoarthritis. I mean, really, we try to look at treating their spine conditions, and if they have spinal myelopathy, trying to see what can be done to improve that. That can be something like a pain stimulator or something that would help with the pain modulation. But it may come down to having to replace a joint, like a knee replacement or hip replacement in some of those patients.
Very good. Moving on to the next question. I have had RA for 30 years and it has never really been controlled. I have never been sent to physical therapy. What are the considerations for being sent to see this specialist?
Well, so physical therapy can become really helpful when you have, for example, a predominant joint that is getting weak because of chronic inflammation and having a hard time performing certain activities. So that would be a good time to do that. But hearing that the arthritis is not control, of course, will make that difficult to even perform the exercises at physical therapy. So the goal should be both things, not the physical therapy alone, but to make sure that then if the arthritis is not controlled, a different medication is tried. It's rare that we reach the point of having exhausted all the different available medications for rheumatoid arthritis because thankfully we have many options. But if it's not controlled, making sure then that treatment is changed is the way to go there.
Very good. And I have one last question here. What is the recommended treatment for seronegative inflammatory arthritis and erosive arthritis?
So, well, rheumatoid arthritis can be seronegative and erosive too. The one thing to, and it would be treated similar. So it would be treated similar to seropositive rheumatoid arthritis. And for those that are not very familiar, we're talking about whether there's antibodies, rheumatoid factor, or CCP antibodies in the blood. So whether they're there or not, the treatment will be implemented equally. You will still be, started on disease modifying drugs. The thing to be mindful of with the seronegative inflammatory arthritis is that it might not have declared itself as what it truly is. So keeping an open mind whether this could be maybe not a rheumatoid arthritis presentation, but rather more like a spondyloarthritis or a different kind of inflammatory arthritis. So keeping an open mind for that is what becomes important, especially in the initial years of presentation.
Yeah, sometimes it can take a little while to arrive to the specific and exact diagnosis. However, you want to start treatment immediately to prevent damage to the joints.
Absolutely.
Now I have a question for each of you, Dr. Geraldino and Dr. Santos. I'll start with you, Dr. Geraldino. What is remission and what does it look like for a person of color versus other races? And what should a person of color reasonably expect when it comes to achieving low pain levels?
So remission for all races, for everybody, would mean that the joints are not swollen anymore, so that the inflammation is controlled. And the things that you would see is that the swelling is gone, the stiffness is gone. Pain, like I tried to mention a bit before, could be trickier to incorporate into the concept of remission or not. Because if, like I said, if we know that there's already damage or there might be other causes for that pain, there might still be pain, but the rheumatoid arthritis or the inflammatory arthritis could still be in remission. So ideally, what we're still trying to address both things. We have to have the inflammation control and achieve that remission, no more swollen joints, no more stiff joints, but we also want to control the pain, and those might be two different things. And it might be that if we know the inflammatory arthritis is controlled, but the pain is still active, then we will go through other routes, not those anti-inflammatory medications, but more so things like I mentioned, antidepressants, gabapentin, or physical therapy, or other things that could help with that pain.
Very good. And for Dr. Santos, how can patients avoid permanent damage and disability with arthritis?
Well, so as we mentioned, prevention, if it's an inflammatory arthritis, to try to get on the right medications. If it's osteoarthritis, weight loss will help. Trying to continue to do aerobic exercise, keep your joints moving, eating a balanced diet. Those things all help. Sometimes it may just be genetic. I mean, there's some people who it just runs in their family, and they may get bad osteoarthritis, no matter how you try to prevent it. And and you can try to buy some time, but it may come down to surgery in the end.
Very good. Well, I'd like to just thank our speakers. A big thank you to you for tonight and lending your time and expertise. I think I can speak on behalf of our audience that we've all learned something valuable to better care of ourselves. So before we sign off for the night, I just want to remind you that we have several resources and events coming up. We have the Navigating Insurance Plans for Arthritis on October 20th. And then we have a Biosimilars What Should You Know workshop on November 9th. To register and learn more about these webinars, please, you can visit the arthritis.org webinar/webinars website. And we have podcasts, helpline, insight programs that are extremely helpful in getting new resources. We have, lastly, a reminder of our survey that will come to you tonight. Again, these are very helpful for the foundation so that we can best serve you in the future. And again, thank you so much for joining us tonight. It's been wonderful sharing this time with you, and I hope that we provided a good workshop for you to learn something helpful tonight.